Thanks everyone for coming to Ortho Conditioning Grand Rounds. It is Wednesday, December 20th, 2023. And future Dr. Noah Elagamy is going to give us a talk on hip fractures.
Yes, thank you. So my name's Noah. I'm a fourth year at Michigan State University College of Human Medicine. I'll be talking about hip fractures today. So just a brief overview of what we're going to talk about. We'll go over some anatomy today, some classification systems for hip fractures. We'll go over some examples of fractures on plain films, and then we'll talk a little briefly on treatment and choice of fixation for different types of hip fractures. And hip fractures are, a common injury. It affects 18% of women and 6% of men globally. And, the incidence increased up until the late 80s and 90s, but due to improvements in the way we take care of these fractures and triaging of these fractures when they come into the ED, as well as osteoporosis prevention, the incidence of hip fractures has plateaued and steadily decreased since then, but it still remains quite high. They represent about 14% of all fragility fractures. They incur an estimated cost of $15 billion annually for the United States. And for a patient who breaks their hip, the estimated 1-year cost of treatment and follow-up visits and physical therapy totals to about $43,000. So that's a little brief introduction. We'll talk about anatomy, and I'll start with the most important part, arguably, the femur. So I'll talk a little bit just about some important bony landmarks that we'll reference later on when we're talking about muscle attachments, and also we'll mention some of them when we talk about the classification systems. So first we'll start with the head of the femur. As you can see here, can you see my mouse, Drew?
Yep.
All right, great. We have the greater troch right here, the greater trochanter, typically referred to as the greater troch or the GT. We also have the lesser troch down here, and between these two, we have the intertrochanteric line. And this bony ridge is an important landmark because that's where the joint capsule, some of the fibers will attach, and that's important when in the overall view of hip fractures. And we'll talk about it later, but you can have intracapsular fractures and extracapsular, and that kind of changes management depending on the location of the fracture. This is a good zoomed in image showing where those joint capsule fibers will come down to right over that iliofemoral ligament. And so the most important bony landmarks, if you're just going to take away a few things from this slide, is the location of the greater trochanter, the location of the lesser trochanter, knowing that the lesser trochanter is a little bit more posterior than you would think initially. And the lesser trochanter is on the medial side, and the greater trochanter is going to be on the lateral side. And Drew, feel free to hop in if you want to add anything at all. Just let me know.
Cool. Sounds good.
Another important concept to understand, and this is a little bit more for the realm of joint replacement, but it's still an important topic nonetheless, is neck shaft angle and femoral anteversion. And I struggled with this a little bit when I first started rotating on the orthopedic service as a medical student, but with a few diagrams, it is pretty easy to conceptualize. So the first measurement would be the neck shaft angle. And so this is an angle that is created by two lines, one that is centered on the shaft or the neck of the femur, and one that is centered on the shaft of the femur. And the angle between those intersecting lines is the neck shaft angle. And this is important to know just to understand the relation between the head of the femur and the femoral shaft, and knowing that it's not a 90-degree angle but rather it's a range of the angle is a normal femoral neck shaft angle is between 120 and 140 degrees, with the average or approximate value being 127 degrees. So anywhere in that range is considered a normal neck shaft angle.
A
The
quick
next thing is, yeah,
quick
go
point
ahead.
on that is you draw a line from the top of your greater troch to medial from that level horizontally. I guess you can see I can see my mouse, but you draw that line from the top of the greater troch medially, and if the center of the femoral head is above that line, it's a valgus hip or a valgus neck shaft angle. If the center of the femoral head is below that line, it is considered a varus neck shaft angle or varus hip. If it almost equates to the center of the femoral head, then you can just call it like neutral. So that's more in kind of the joint arthroplasty, hip arthroplasty realm, but it's a good quick method to kind of immediately tell, is this a valgus or a varus hip? So looking at this little diagram, I'd say that's a varus or a
Yep.
valgus hip.
Valgus hip. Yeah, and Hip and Knee Book, which is a free resource online, also has a chapter that goes over neck shaft angle and anteversion, and they have some good illustrations on there as well.
A good
Mhm.
definition that I don't know if everyone talks about, like what is valgus? It's the distal aspect of whatever you're talking about, the distal aspect pointing away from midline, versus varus is the distal aspect is pointing more towards midline. And it even works in the hip because you're going to have a wider angle with the distal aspect of the femur pointing more away from midline. So that's another way to think about it.
Yeah.
Excuse me. Keep going. Sorry.
Yeah, and for femoral version is formed. The definition is that it's formed by the angle of the axis between the femoral neck and the transcondylar femoral axis. So this illustration is a good way to think about it. So we're looking top down over the femur and directly down over to. Imagine you're standing over someone's hip and looking directly down the shaft of the femur. So you have your femoral head here, and this is going to be your greater troch here, and this is going to be the distal femur right here, the condyles right here, and so this is going to be below where your eyesight would be. So when you're looking at this, the femoral head isn't directly in line, or it doesn't have the same angle as the distal femoral condyles. So if it's anteverted, it's going to be greater than 20 degrees, and if it's retroverted, it's going to be less than 5 degrees. Anything you wanted to add on that? I know this is kind of a difficult concept. At least for me, it was difficult to conceptualize at first.
The only thing to add is that just like this seems like not useful, but it actually is. So a lot of what you talk about in hip arthroplasty, trauma, even, is like acetabular version versus femoral version. And if you can burn this image into your head, this is femoral version, whether it's more anteverted or more retroverted. It's all in reference to the distal femoral condyles, and those are at the knee.
Yep.
So those little white patches are the articular surfaces of the distal part of your femur that articulate with your tibia or at your knee joint. So there's a lot of OID questions that talk about femoral version, both in arthroplasty and trauma, because you can change your version on accident if you malalign a femoral shaft fracture. So if you don't have a good reduction and the distal aspect of that fracture is rotated one way or another, you can actually give someone more or less femoral version, and it can cause in-toeing or kind of like a duck gait where their feet are pointed way out. but that gets a little more complex. But that's a really good diagram.
Yeah, very useful to take a peek at to refresh yourself on it, because I found myself constantly forgetting what we were measuring in relation to what for version, so it's nice. Another important concept is the calcar, and this is a dense cancellous strut of bone, or a dense part of the bone that extends from the posterior femoral neck, so that'll be up here, to the posterior medial proximal femoral shaft. And so the calcar plays a critical role in providing structural support and allowing stress distribution from the femoral head to the proximal femur. And so its presence or its absence plays an important role in appropriate implant selection for hip fracture treatment. And we'll talk about that a little bit today when we talk about intertroch fractures. But that's a kind of another presentation on its own that hopefully we can discuss at some point. And so these are kind of thickening. The calcar is a kind of a thickening of the bony trabeculae, and this is a dissected out cadaveric femoral head and neck that shows the area of the calcar.
So it's kind of like the posterior medial aspect of the intertroch region near the lesser troch. So I used to get confused by this. It's not just the lesser troch. So you can have an avulsion of that little nub, aka the lesser trochanter, because it's an attachment to your iliopsoas tendon. And it doesn't necessarily equate to having a really unstable fracture. Where you have the unstable fracture is where it's kind of the lesser troch plus that strut of bone. It's just like a little more heft to it in that posterior medial aspect of the femur in that area. So
we'll go through muscular anatomy here as well, and I kind of think of these as three categories. So I think of the first category being the muscles that attach to the greater troch. That's going to be the glute medius and the glute minimus, and you can see the attachments here. This side being anterior, this side being posterior. And so we have the glute med and the glute minimus. These are the main hip abductors. So when we're looking at how a fracture can displace, it's important to know where the muscles which muscles attach to which part of the femur, and knowing that when there's a fracture, those muscular attachments can pull those fracture fragments and shorten the muscle, which will pull that fracture fragment out of alignment. So it's important to know your muscular insertions. For the lesser troch, the important muscle here is the iliopsoas, and you can see the iliacus and psoas becoming a confluence and attaching here at the lesser troch, and that's going to be your main hip flexor. And then the last category that I think of are external rotators. These are going to be the piriformis, superior, inferior, gemelli, quadratus femoris, and obturator externus, and these will insert along the superior-medial aspect of the greater trochanter right there.
So I've heard it pronounced gemellus more frequently, probably. If you were to memorize one thing from this slide, you want to measure or memorize your short external rotators, which are piriformis, superior, inferior, gemellus, quadratus femoris. Excuse me. So these in order, and internal obturator. So these in order from top to bottom, like you will be asked this on your, if you're shadowing in total joints, you'll be asked this if you're doing a Coker-Langenbach approach for acetab ORAF, anything that sometimes, there's just so many contexts where this applies, and those tendons are essentially attaching in the piriformis fossa area, which I don't know if you have a good diagram of that, but it's kind of in the posterior aspect of the greater troch, but there's like a little dip right before the femoral neck starts.
Mm.
Yeah.
Are you talking about up here?
Yep. So piriformis fossa area. But
Excellent.
yeah, people will ask you what are the order of your short external rotators, and you need to just be able to rattle that off. Piriformis, superior gemellus, internal obturator or obturator internus, inferior gemellus, then quadratus femoris.
Awesome. The most important thing to know about vascular anatomy is that the vascular supply to the femoral head and femoral neck is quite tenuous. And so the main supply is going to be your medial femoral circumflex artery. So that's going to be this artery right here. And so the femoral head has a retrograde blood supply, and it's a tenuous blood supply. And so it's important to understand that, because if you have a femoral neck fracture, it can easily disrupt the blood supply to the more proximal aspect of the bone, and this can lead to avascular necrosis. So we'll go through some classification systems. The most broad overview of hip fractures is to classify the fractures by location. And so the three most important locations to understand, at least at a medical student level, are the femoral neck femoral neck fractures, or the intracapsular fractures, the intertrochanteric fracture, and the subtrochanteric fracture. And this is another diagram showing those areas highlighted on the bone. And I'll get through, once I go through each category, I'll give a more detailed description on the definition of what makes a femoral neck fracture and what makes an intertrochanteric fracture that. So first we'll start off with femoral neck fractures, and the most important or high yield classification system, you can even argue for hip fractures in general, would be the Garden classification, to understand, and this is because the Garden classification can guide treatment, and we'll see that when we go over fixation methods. But very simply, the Garden classification can be simplified even further than this by saying that stage 1 and stage 2 are non-displaced fractures, and stage 3, are non-displaced fractures, and stage 3 and stage 4 are displaced fractures. So stage 1 is going to be a non-displaced fracture that's incomplete. And these fractures, they can be termed valgus impacted. I don't have an image of that up, but if you Google valgus impacted femoral neck fracture, it's very easy to appreciate it. Garden stage 2 is going to be a non-displaced fracture, but this one is going to be a complete fracture when compared to stage 1. So stage 1 is going to be incomplete fracture, non-displaced. Stage 2 is going to be complete fracture, but it's still non-displaced. Stage 3 is where you have a complete fracture that is incompletely displaced. And stage 4 would be a complete fracture that is completely displaced. Another way that you can classify femoral neck fractures is the location on the femoral neck where the fracture is occurring. So you can have a subcapital fracture, sub meaning below, capital meaning head, so it's right below the femoral head. Transcervical, trans meaning across or in the middle, and cervical meaning neck, and then basicervical meaning at the base of the neck, and that's going to be right up, right by that intertrochanteric ridge, but still on the femoral neck. And then here on this diagram, we also have the location for an intertrochanteric fracture, or an IT fracture, and a subtroch, and these are extracapsular. So IT fractures, these are common.
Do you talk about why intracapsular versus extracapsular matters?
We can talk about it now.
Sure.
So intracapsular, it's important because if you have a fracture that's intracapsular, meaning you have a fracture of the femoral neck, the odds that you are damaging that medial femoral circumflex artery are high. And so the risk for avascular necrosis of the femoral head is also high. And so that guides fixation or implant selection, because you'll want to do something like a hemiarthroplasty, where you're replacing that femoral head, because you don't want to do a procedure like cannulated screw fixation, where you can down the road run into avascular necrosis.
Yeah.
Is that
So
what you were getting at?
yeah, exactly. So intracapsular fractures. Displaced femoral neck fractures that are either subcapital or transcervical. Technically, basocervical femoral necks are usually outside the capsule, but subcapital, transcervical, intracapsular, displaced. There's a couple theories whether it's synovial fluid getting into the fracture site or a likelihood of, and it's like the tributaries of the medial circumflex artery, these small little retinacular vessels that shear and break off, and you have a lack of blood flow to the femoral head. But overall, the takeaway is these types of fractures don't heal well if you try to put them back together and fix them in an elderly osteoporotic hip fracture. So that's what the Garden classification is for. It's for femoral neck fractures in the elderly. It's not necessarily meant or designed. It was not originally made for a high energy young like MVC femoral neck fracture, because technically we still try to ORAF or fix the intracapsular ones for young people. But for older individuals, where we say, based on our research and literature, that they don't heal as well when you try to put them back together and fix them with screws, then you say, well, patients tend to do better if we just take that whole piece out, the femoral head, and put an arthroplasty in instead, whether it's a hemiarthroplasty, like half of a hip replacement, or a total hip. So,
Yep. Yeah, that's a great point to make as well. So this whole presentation really is kind of geared towards that elderly hip fracture type of patient, and not really, like you said, a young MVC accident.
well, I remember thinking that the Garden classification applied to young femoral necks when I was a med student, and I brought it up, and everyone was like, "Whoa, whoa, whoa! What are you doing? You can't Garden classify this high energy femoral neck and say you need to just chop it out and put a hip arthroplasty or a hemi in there." And I was like, oh, I didn't realize that. So you should equate elderly with Garden, and then other classifications with younger femoral necks.
Yeah, great point. So IT fractures, these are common extracapsular fractures of the proximal femur at the level of the greater and lesser trochanter. And so this region is highlighted right here. We're going to see for subtroch fractures, I think the definition for that is 5 centimeters below. This is a textbook definition, 5 centimeters below the lesser troch.
Highly testable.
Yeah, highly testable. But this is the area of where IT fractures occur. I did allude to this earlier about stable versus unstable intertrochs, and this depends on a variety of factors. Hopefully, we can touch on it in future presentations. But if you can look at a hip X-ray and tell whether or not it's a IT fracture versus a femoral neck fracture or a subtroch. I think, and Drew, you can weigh in on this, I think you're in a good spot as a medical student.
Yeah, truthfully, like if you take this presentation to heart and you can look at an X-ray and say that is a displaced femoral neck fracture, and that's the end of how you describe the image, you will be ahead of 100% of your peers.
Yeah, and there is truth to that statement.
90%.
And I'll have plain films of some fractures, so we can talk about IT fractures versus femoral neck fractures at that point as well, because sometimes they can be difficult to tell apart. And this is a subtroch fracture. So this is going to be a proximal femur fracture that's located, like I said, within 5 centimeters of the lesser troch. I think that's the Ortho Bullets definition of a subtroch, because anything lower than that would be classified as a midshaft femur fracture, correct?
Yeah, you can just call it a femoral shaft after that point.
Yeah. Yep. So now we'll go through some plain films. So I'll ask if anybody wants to hop in, try to read this. If not, it's okay. We can go through it. But I wanted to make the offer at least.
I say talk through the first one. Get us rolling.
Yeah, so read it so tell me what you see on the... Tell me what makes you
As in
think
if it's like...
see.
Okay, so I'm looking at the greater trochanter and looking at the lesser trochanter, and it looks like the line goes through both of them from one end to the other.
Mm-hmm. Yeah, and I tried to highlight some of the fracture lines. So the red would be the femoral neck right here. Green is the lesser. I think this is the little nub of the lesser right here. Oops. And then blue would be that fracture line right there.
That's some high quality outlining right there.
High quality outline, you think so?
Yeah, I love that.
Yeah, so like you said, you can see the fracture line going and involving the greater troch and the lesser troch. So this is kind of textbook intertrochanteric fracture. Good job.
And so if you were to read that in a rotation setting, you would say this is an AP of a left hip showing a left comminuted intertroch fracture or femur fracture. And then if they want to ask you more questions about that, you can go into more details, but concise and full picture of what it is kind of what you want to shoot for.
Yeah. And I think one pitfall that I find myself on into when talking about x-rays is I think a lot of things that are obvious might be a little too obvious to say out loud. But like Drew said, if you just say like, oh yeah, this is a comminuted. Yep. Go ahead.
I was just going to say, you say the x-rays you're seeing, like, is it an AP lateral? And then you can say skeletally mature or skeletally immature individual. And then you say exactly what you see. You jump right to what the pathology is and just say it in the most clear, concise way possible. Mm-hmm. And then in real life, you identify the injury right away, but then you have to look at everything else to make sure you're not missing anything.
Yep. Great. All right. I don't think I would get this one right. Do you want to try again, Marquisha?
Yes, I will try again. So this is an AP image of a skeletally mature person. I'm not sure how to differentiate left from right yet, but I would assume this is right. Is this right?
Yep.
Okay. And then, it almost looks like there's an trochanter partially down to the lesser trochanter, but not completely.
So what would you call it?
It's not displaced, and it's incomplete. I forget if we call it partial. I'm not sure.
Yeah, you could say incomplete. This is what I ended up highlighting. I would say it's displaced. It looks like it might be a complete fracture. This is an intertroch fracture. And I feel like this is one of those for me where I could, if I looked at this, I would think it's a femoral neck. And I wanted to get Drew's input on pearls and pitfalls for him when he's reading these X-rays, what he's looking for femoral neck versus IT.
Yeah, it can be hard sometimes, and sometimes you have to get a internal rotation traction view, where you literally pull on the person's leg while internally rotating them, and this helps put the fracture lines, especially if they're significantly displaced, they'll be less overlapped, and they'll give you a better profile to see where that fracture line actually goes. With this one, you can see a little bit of that shadow that goes out the tip of the greater troch. Past your, yeah, exactly. So if I'm seeing that and I'm like, okay, this is exiting through the greater troch, then I'm calling it an inner troch.
Mm.
And with inner trochs, really, you don't necessarily think of them incomplete versus complete. Usually we think about them as stable or unstable, which is, we'll get into more details at a different talk, based on their morphology and what factors they include in their fracture pattern. But using terms like displaced or non-displaced is totally fine. That's another good describer. So I would call this a right minimally displaced inner troch or a stable inner troch.
Cool. Thank you.
Yes, and then so getting into how do you tell it from a basocervical femoral neck? Usually the basocervical femoral necks, they all have a very similar look, where if you follow the medial aspect of your femoral neck down, that fracture line always ends before it hits that region of the beefier part of the inner troch and the proximal femur. So that fracture line will look like it immediately stopped at the start of the femoral neck. But it can be difficult to tell. And inner trochs are easy to miss, because sometimes they just have this like wispy looking shadow that goes through the inner troch, and you're like, is that even a fracture, or is that like a soft tissue crease? Sometimes it can be a little bit confusing. So this is typically what they look like, little shadows going across the inner troch area.
Right. I think I could probably give this one a shot. So we have AP of the right hip and a skeletally mature individual. So I see a displaced, complete femoral neck fracture. If I had to classify this, I'd probably say Garden 4.
And so can you perfectly tell, like, what other images would you want in the hip series?
So you can get cross table lateral. You could get a traction view.
So what's typical of a hip series?
Hip series, so you'd have AP.
Yep.
You'd have lateral.
Yep. So either frog leg or cross table lateral. I would say, for whatever reason, the trauma surgeons really like cross table laterals at our institution. So we always need to have a cross table lateral. And then what else?
Would you get full length femur?
For hip series,
or would that be,
at least.
Well, not, yeah.
Ours includes a AP of the pelvis. So it can be really helpful to be able to look at the other side, almost in like a comparison. So AP pelvis, AP hip, and then cross table lateral.
Okay. And this is the fracture line I see.
Yep. And you guys probably can't see my cursor because I'm not the one screen sharing, but if you follow the femoral neck from the more distal aspect of it, where it starts off the inner troch region, and then see where it ends, and there's like a density of where that fracture line comes across from medial to lateral. you can almost usually see it through the head.
Mm.
So if you move your cursor more to the left of the screen, or at least left of my screen, you can see how there's like a dense line, like jaggedy dense line.
Oh, right here?
Yep, exactly.
Oh, yeah. Okay.
So you can almost see where the femoral neck fracture actually is.
Mm.
But, if you saw this, you'd be wanting to verify it on other views,
Mm.
versus just calling it a displaced femoral neck immediately from this view, even though it likely is.
Mm. I think this is our last one.
I can try this again. So this is an AP image of a skeletally mature person of the left femur. And there's a fracture line that looks like it's subtrochanteric or under the lesser trochanter.
Yeah, so this is a subtroch. Is there a name for this chevron type of like fracture pattern, Drew?
No, but if you're seeing subtroch fractures, you have to be a little bit like, okay, what was the history? How did it happen? Because especially with like kind of weird looking transverse subtroch fractures, you have to be thinking of atypical femur fractures. Atypical femur fractures are caused by medications like bisphosphonates, and they make a little bit of a beaking in that area, almost like a stress riser, where you'll get these weird looking, almost transverse subtroch femur fractures.
Yeah, well, I actually saw a bisphosphonate fracture, and it had like the typical beaking, and it was just a transverse femoral shaft fracture. So yeah, exactly. If you ever see like a transverse femoral shaft fracture, you should be thinking atypical. Exactly.
Or transverse subtroch.
Transverse subtroch.
Yeah. And usually you need to check the other side as well. But Marquisha, you had the right exact thought of exactly where this fracture is. It's below the lesser, and it's just connecting the dots with the naming with it's in the subtrochanteric region beneath the lesser. So it's from that lesser all the way distal 5 centimeters from that point. So sometimes it can be helpful you can, on these imaging software systems, you can measure the distance from your lesser down and see where kind of that fracture is. And if it's within 5 centimeters, you can comfortably call it a subtroch. But it's also another reason why having multiple views is helpful, because you can look at your lateral and say, oh, this looks exactly like a subtroch because of this other feature. Do you know what it is, Noah?
For a subtroch?
Yeah. What does the proximal segment do?
Well, it would adduct or abduct.
And?
It would abduct and externally rotate.
Yep. So it kind of flexes, abducts, and externally rotates. For all the things you said are connected to that piece. So you have your short external rotators, you have your abductors, and you have your iliopsoas tendon connecting to an intact lesser troch. So if you look at these from a lateral view, they'll literally be flexed up, almost looking like they want to come out of the skin. Sometimes they're so flexed up in reference to where the shaft is at, and then you can be like, hey, that looks exactly like a subtroch, and it's behaving like a subtroch because those pieces are still intact.
Yeah, and that's a great tie-in for knowing the muscular anatomy.
Yeah, and so the difference between, and maybe this gets into more of the intertroch talk that we should probably have, but intertrochs, sometimes they can be comminuted and they can have extension into the subtroch area. But if it's a lot of comminution with the extension of the fracture lines in the subtroch area, you may not have a same typical behavior as a true subtroch with the flexion, external rotation, abduction of the proximal piece. So technically you would call it a intertroch with subtrochanteric extension versus a true subtroch, if that makes sense.
Yeah, that helps.
So the diagnosing, I think the biggest takeaway with, do you have more images of femoral necks?
Femoral necks, I don't have more on the slides right now.
Okay, no worries. The biggest thing is being able to tell, is it displaced or non-displaced? Excuse me. Memorizing the Garden classification, and really it's a little bit of confusing. You have to think of Garden 1s as they might be displaced, but they're kind of tipped back, where they're crunched in on themselves and tipped back, almost like someone takes an ice cream cone and just mashes it down into a more valgus position. So that femoral head and neck will tip into a more valgus position or back, and it's technically angled in a way that creates what we call apex anterior, meaning the apex of the displacement, or the most kind of the fulcrum of where it displaces on, is in the anterior aspect of the femoral neck, and it tips posteriorly. But on an AP, it looks like that femoral head is tipping into a more valgus position, and that's why we call it a valgus impacted femoral neck. So they tend to be quite stable because they've kind of crunched in on themselves. Sometimes patients can even walk on valgus impacted femoral necks. Whereas if you go to a Garden stage 2, a non-displaced complete, you'll have a fracture line there, but sometimes these are really unstable. And you have to be suspicious that maybe we can get away with just pinning them in place with screws, but sometimes you check them in the operating room and you move them around and see if they're moving together. And if we've had a couple that just are not stable at all, despite them looking like they're just a single fracture line that is not displaced, and we still jump to a arthroplasty option. So with saying that, Noah, why don't you go into kind of the treatment options really quick?
Yeah, definitely. So kind of similar to what we were just talking about, I kind of group Garden 1 and 2 together and Garden 3 and 4 together, because exactly like what you were saying with a Garden 1, because these are typically more stable, you can get away with screw fixation. But with a 2, you need to have a high index of suspicion that it might be an unstable fracture. And if in the OR it's unstable, to switch to a method that you would use to fix an unstable or a displaced Garden fracture, which would be 3 or 4, and that would be like a hemiarthroplasty or a total hip arthroplasty. And because 3 and 4, these are complete fractures, and these are intracapsular fractures, and for all the reasons that we discussed earlier, related to AVN, typically for these patients, they'll undergo hemiarthroplasty, which is kind of a half of a hip replacement, where you keep, you'll surface or resurface the acetabulum, and put in the femoral component of a hip replacement. For patients who have
technically with the hemi, you don't resurface. So you leave the acetabulum just pure cartilage.
Oh, okay.
Yep. You leave it alone, and then, but you do cut out the fracture and put the femoral stem, and then pop on your new shiny metal femoral head.
And it's a little bit different for patients who have like a underlying hip osteoarthritis, or it's a a patient who is physiologically young, super active, on their feet a lot, then typically the discussion is had, and it's taken into consideration whether or not a total hip arthroplasty would be better. Because if you think about it, if they have bad hip arthritis already and you do a hemi, then you might down the road have to revise it to a total. And that's kind of how I think about it. Hemis for patients who are older, less active, totals for patients, and this is a very oversimplification, but hemis for patients who are older, less active, totals for patients who are either have underlying hip osteoarthritis or are younger and more active, more on their feet. And then I wanted to briefly talk about sliding hip screws as well. These are biomechanically superior to cannulated screw fixation. That's that's kind of another talk, so I don't want to really get into the weeds too far. But I would say out of all the hip fractures I've seen, which is not too many compared to what Drew has seen, I haven't seen sliding hip screws used as often as like hemis are, or even I've seen actually cannulated screw fixation more than sliding hip screws.
Yeah, so you wouldn't really compare them with the arthroplasty, but you would compare them with the screws. So in young patients, generally the go-to is sliding hip screws with femoral necks, with sometimes a cannulated screw that acts as what they call an anti-rotational screw. But I would say, and so you can use sliding hip screws for stable intertrocks. So this pattern that's shown in this image is a stable, just simple intertroch.
Yep, and that's that's the next slide.
Oh,
So
perfect.
stable, you could use sliding hip screws or a cephalomedullary nail. And the cephalomedullary nail, is used for unstable intertroch fractures as well. I would say I've seen more like CMNs or cephalomedullary nails more than sliding hip screws as well.
Yep. And I think it's just people are more used to them, but it used to be all sliding hip screw back in the day. But I think sliding hip screws are technically cheaper, even though maybe recently maybe the nails have become fairly comparable, or they have become more cheaper than when they first came out. But for stable versus unstable intertrochs, you have to think of, okay, we could do a sliding hip screw or a cephalomedullary nail. And technically you could do a short cephalomedullary nail, which is depicted here, versus with unstable intertrochs, you cannot use a sliding hip screw as an option, and you should be using a long cephalomedullary nail for an unstable intertroch. Let's talk for a different day. Go back to the last slide, though, really quick, for the femoral necks. The thing to take away is, for displaced femoral necks, you can consider fixing them with screws. And
For non-displaced.
Yes, sorry. Did I say the opposite?
You said for displaced.
Gosh darn it. Okay. We're going to get this straight. We're going to get it correct. So for non-displaced, garden 1s and 2s, you can consider fixing them with screws. And the pattern is inverted triangle. That's another testable thing. And I would say that at least at our institution, that's kind of the go-to for those fractures. And then for displaced, garden 3 or 4, that's when you're thinking of the arthroplasty option, whether a hemiarthroplasty or a total, for the reasons that Noah just talked about.
Yep.
And I think that's a good place to end. Trying to keep it.
Yep.
That last few sentences said in the correct way. If you can memorize that, you're way ahead. You're way ahead of the game. And truthfully,
I agree.
I kind of wish maybe one day we'll recruit a bunch of ED physicians to join us, because I think it'd be helpful for them to understand kind of the decision making behind what we do. But yeah, we won't call you guys med students. We'll just call you future orthopods. near future orthopods, because the med student years go really fast. Also, just talking about the stuff, saying it out loud, thinking about it, it's gonna make a huge difference, because it just starts to get ingrained in your brain once you've seen it like 100 times. That's kind of what it takes, just seeing it over and over again. But yeah, nice job, Noah. Good breakdown. Future talks. Almost as a recap, let's try to pull up more hip fractures and just practice being diagnosing them, being like, this is a displaced femoral neck, or this is a valgus impacted femoral neck, and then we can go through some examples.
Yeah, that sounds great.
I think just for advertising purposes, because I don't take sponsorships or advertising money, I'm gonna tell people, go purchase the Atlas course. We're gonna have breakdowns of everything Noah talked about, to make this like as clear as possible, with kind of walkthroughs of essentially notes from what Noah discussed, like when to use a hemarthroplasty, when to use a total, what should you be asking, and how you can stand out on your away rotations and know what you're talking about. So that's my plug for that. I'm just going to keep plugging it, because it is helpful. I think when people invest in being like, okay, I'm gonna pay to be involved in the community, I'm gonna pay to be involved in my learning, that they actually do it. They're actually like, oh, I paid for that, I need to go do it. Versus the experimentation I've had with just like, here's all this material. I'm just giving it to you. People just kind of forget about it and they go do something else and never come back to it. So it's kind of like an investment. But that's all I'm going to say about that. Anything else you wanted to bring up, Noah?
I just wanted to also mention the Atlas course has great resources for interviewing as well. I was using it for some of my interviews that I had coming up, and it was super helpful. So that as well.
Was it really like actually helpful?
Yeah, no, it was. There's a lot of good practice questions in there, questions that you can think of, or suggestions for questions to ask attendings, whether that's the program director, department chair, questions to ask residents. So really just all around a good resource to take a peek at the night before your interview.
Nice. Yeah, that is that list I added into the course is actually what I used for fellowship interviews as well. And I took a lot of the things I learned from my residency interviews and tried to translate it into my fellowship interviews. So there's a lot of interview suffering that I went through that now hopefully you can have less suffering when you guys go through it. But no, like now that you've gone through that, keep track of kind of what you see in your interviews, and maybe where we can fill in the gaps. If I'm missing anything or something, you're like, oh, I wish I would have known about blank. Because
yeah,
I wish I would have had something like that.
Yeah, I'll keep an eye out for it.
Sweet. Thanks for mentioning that. Well, cool, guys. It is a few days away from Christmas, so hopefully everyone is going to go do something fun. But thanks for joining us for Ortho Conditioning Grand Rounds. You guys have a good night.
Thanks, everyone.